It's really a great pleasure for me now to invite Dr. Jeffrey Horbar to speak. Jeffrey is a board-certified neonatologist and professor of pediatrics at the University of Vermont College of Medicine. He is the chief executive and scientific officer of the Vermont Oxford Network, a consulting editor for pediatrics, e-pages, and co-editor of the neonatal review group of the Cochrane Collaboration. Dr. Horbar has been responsible for the development of the Vermont Oxford Network and its database, which is used by over 900 NICUs worldwide, including TCH and now also the Hospital San Jose in Mexico. Dr. Horbar is really one of the true visionaries in our field and really all of medicine, because really neonatology is very fortunate to have an institution as the Vermont Oxford Network that literally does not exist in other areas of medicine. It's a great honor that he can be with us today in support of this project. Dr. Horbar will introduce the Vermont Oxford Network and provide us with some insight into what is possible when NICUs collaborate to improve quality of care for patients and families. Please welcome Dr. Horbar.
Thank you very much, Jochen. It really is a great pleasure to have this opportunity, and I want to thank you and Dr. Trevino for inviting me to be part of this project and to give you a brief presentation on today's webinar. What I'd like to do is give you a brief introduction to the Vermont Oxford Network and also to welcome the Hospital San Jose to membership in our network. We hope that over the years we'll have the opportunity to work with you and all of our colleagues at Hospital San Jose, but also many other NICUs throughout Mexico. Etienne Wenger has described a community of practice as a group of people who share a concern or passion for something they do and learn how to do it better as they interact regularly. And when we became familiar with this term, we recognized that this really describes our vision for the Vermont Oxford Network, because what we're trying to support and create is a worldwide community of practice that is dedicated to providing every newborn infant and family with the best possible perinatal and neonatal care. I think the CUSP project that you're embarking upon today is really a wonderful example of how to put these ideas into practice. The Vermont Oxford Network started in 1989 or 1990 with just a very few neonatal units participating. And as you can see on this slide, over the past 20 years or so, we have grown quite substantially. We now have well over 900 NICUs in 32 countries participating in the Vermont Oxford Network. And a growing number of these NICUs are outside of the United States, which is a wonderful trend that we would like to see continue and learn ways to encourage. This slide shows on the right side the growth in NICUs, but on the left side the growth in our very low birth weight database. In support of our vision and mission to improve care, all of our members participate in our very low birth weight database and submit data to us on their very low birth weight infants. And we're now currently collecting somewhere between 60 and 65,000 very low birth weight infant records each year, including probably about 80% of the babies in that birth weight category born in the United States. The Vermont Oxford Network tries to provide a number of projects and programs to help our members measure their performance, learn both from one another and from experts in the field, to continually improve the care that they provide through the application of standard quality improvement methods, and I think CUSP is a wonderful example of this. And also, very importantly, to share the learning with one another so that multidisciplinary teams that include nurses and doctors and parents can meet together and share their experiences and learning so that we all together can improve the quality of care. The very low birth weight database, in which I mentioned all of our members participate, includes all infants 401 to 1,500 grams or 22 to 29 weeks. Our member hospitals also have the option to submit data on all of their NICU infants, and all of the members are able to access secure, confidential online reports that allow them to compare their performance with that of other NICUs like theirs, with the network as a whole, also to see trends in their data over time using our Nightingale Internet-based reporting system. One of the things which we've learned and continue to see year after year, and pretty much I think every area of medicine which has looked at this has found the same thing, is the very dramatic variation both in practices and outcomes that we see among neonatal intensive care units. This slide shows the data from a few years ago for infants at 850 of the NICUs that participated in the network in 2010, and shows the outcomes of death, any hospital-acquired infection, and chronic lung disease. And the orange part of the bar shows the interquartile range. The upper and lower limits show the 10th and 90th percentiles, and the gray dot shows the overall rate for the network. And as you can see, for all three of these outcomes, there's extremely large variation. For mortality, there are some units with mortality rates under 5% and others over 20%. For chronic lung disease, even more extreme. Now, these data are not risk adjusted, so some of the differences that we're seeing here may be accounted for by differences in the risk factors for the patients that are treated at the units. But even after we apply all of the best statistical techniques that we can to adjust both for differences due to risk and differences due to chance, we still see very dramatic variation. And let me just explain briefly what this slide is. These funnel plots show the observed minus the expected number of cases at each unit in the Vermont Oxford Network. The observed is just the number of cases that were actually reported by that hospital in the given year. The expected is a number that we calculate based on regression models that take into account the different risk factors for the types of patients that are treated at those hospitals. And even after we do that, you can see, and on these funnel plots, hospitals, the smaller hospitals are to the right of the funnel, and the bigger hospitals are over at the left. Hospitals that are shown in blue dots have fewer cases than would be statistically expected. So you can see for chronic lung disease and infection, for instance, there are quite a few blue dots. That means that there are quite a few hospitals doing better than might be expected based on the case mix of the cases that they treat. But you can also see that there's a lot of red dots. Just focus on infection, which is the lower right-hand panel of this slide, and which is going to be one of the key improvement outcomes for the CUSP project. You can see there are a lot of red dots. Those are hospitals that have more cases of infection than would be expected based on the characteristics of the patients. You can see, if you look at the left side of that funnel, there are some large hospitals that have more than 40 cases a year, more than would be expected. Obviously, a lot of room for improvement in this particular outcome. One of the ways that we try to promote learning among our members is at our annual meeting in Quality Congress. Our next one is going to be in Chicago this coming October. And Dr. Trevino, it was a pleasure to meet him at our last annual meeting, and I think he saw perhaps the opportunities there for hospitals to really dig down at a very deep level to understand each other's practices and share them with one another. And I hope that we will will see many of you at future events of the Vermont Oxford Network. In addition to the learning opportunities at our annual meeting, we have conducted since 1995 a large number of quality improvement collaboratives where multidisciplinary teams from member hospitals meet together under expert guidance to identify, implement, and test potentially better practices for improving care. These are both face-to-face ones that we call NICU or internet-based collaboratives that we call iNICU, and well over 400 teams have participated in one or more of these over the past number of years. I mentioned the word potentially better practices, and we intentionally use that term rather than the word better or best practices because it really, we've discovered, and many others have as well, that you can't really claim that something is better or best until you've adapted them and tested them and proven that you can make them work in your local context. And I think that is going to be an important part of the work that you confront as you move forward with CUSP. So again, our vision is a worldwide community of practice where health professionals and parents from neonatal units around the world can share their improvement learning and work towards the common goal of improving care for infants and families. We very much look forward to working with all of you and many of the NICUs in Mexico to strengthen this worldwide community of practice. This slide, just to end, shows that there are emerging collaborative groups of neonatal units, both within many of the states within the U.S. on the left side of this slide, internationally among many countries, and also within quite a variety of administratively organized neonatal groups. It's my hope that a collaborative will emerge in Mexico that will become a strong contributor to this worldwide community of practice. So thank you very much for your time. I look forward to getting to know all of you and working closely with you, and please feel free to contact me if you have any questions. Thank you.